To win any battle, we need a strategy. It is not the strongest, it is not the most brave, it is the most strategic that win the race, is what you need to be very sure. For everybody, what is the common constraint? Time. It's not that we are not brilliant or someone who didn't make the entrance is not brilliant. Only thing is time. Time is common to everyone as a limited resource, and within that limited resource, how well we are able to give a completion to the task of revision is all the challenge about MD entrance. So today by evening, you should leave this room with a brimming confidence that yes, we are ready to face general medicine, 30 questions in DNB CET. So that is the whole idea. So what is the strategy? In the last 15 years, there are totally 30 instances where DNB CET was conducted. Every year 2 times. Every year around 300 questions are released. So every question we labeled which topic it belongs to. And we brought all questions belonging to the same topic to one place. Then we have asked the computer to arrange the topics in the descending order of priority. How many times they have been asked? Some topics have been asked 30 times in these 30 exams in the last 15 years. Some topics were only asked 2 times, 1 time only in the last 15 years. We can definitely ignore those topics. So what is the strategy? The strategy is, there are 28 topics. Totally there are 620 MCQs in the last 15 years asked in general medicine. Out of that, 28 topics were asked 323, 28 topics, 323 MCQs were asked. That means 50% of times questions came from these 28 topics in the last 14 years. 16 MCQs out of 620. That means 10% questions came from 11 topics. There are 155 MCQs which are 25%, 1/4 of 600 came from 43 topics. So 43 plus 11 plus 28, if you finish, 82 topics, 85% of your general medicine preparation for DNB is over. Then there are 61 topics, only 1 or 2 times they have been asked. Really you can ignore them. For example, multiple sclerosis. Multiple sclerosis is a very high yield topic when it comes to all India PG medical entrance. But it is asked only 2 times in last 15 years. To read multiple sclerosis, at least you need to invest half an hour to 45 minutes of your time. If you don't have time, you can always ignore confidently the topic of multiple sclerosis. That is the whole idea. So let us make the great review. We invite Anu, Krishna, Rohit from Bhopal and Judal, Neelu and many students across India. Can you please punch whether the voice is loud and clear? The online students. They have gone to get the photocopy of the notes. Don't worry, they will give you the notes. You need not write anything. So 28 must read topics. 50% of times they appeared. What are they? HIV. Highest number of questions came in DNB CET. Can you get me some water? Stroke. Then electrolytes. Hypo, hyper, calcemia, magnesemia, kalemia. Then myocardial infarction, diabetes, then one of the valvular heart disease, very high yield topic. Acidosis, acid base disturbances, neuropathy, anemia, HBV, HCV, cystic fibrosis, etc., etc. The list of the 28 topics first we will master. Then there are 11 topics: aphasia, chronic renal failure, multiple endocrine neoplasia. They have been asked about 10% of times. Then there are 43 topics like amyloidosis, Addison's disease, asthma, cardiac tamponade, etc. They have been asked around 25% of times. Then 61 topics lastly asked only 1 or 2 times. So let us make the great beginning with HIV. The first topic. Which drug is not preferred when you are treating a patient of HIV with TB is a very important question. Another half an hour they will get you the notes. Don't worry about it. We will give you all the notes. About 250 pages of notes is there, which you can review. All 620 questions are there in that. So it is a nevirapine which is not preferred in the treatment of HIV whenever they are having a concomitant TB. Generally, what is the preferable drug? We give efavirenz or either lamivudine or the lamivudine or stavudine. Similarly, if HIV patient is there with a TB, along with rifampicin, which drug is the one which you prefer to give? So, ritonavir among these drugs is the one which is preferred to be given. So, HIV plus TB, what is the protocol? Any patient who has got TB, what is the best and most recommended antiretroviral therapy is the favorite question of the examiner. So what is your answer? There is a regime 2, regime 2A, 2 regimes which have been prescribed by the World Health Organization. Zidovudine, lamivudine, efavirenz is what you can give if the patient is already on ATT. If the patient is on ATT and if he is having anemia, what is the main side effect of zidovudine, doctor? Zidovudine lead to bone marrow depression. So you don't want to take a risk if already patient is having anemia. So in that kind of patients you use stavudine, lamivudine and efavirenz instead of zidovudine. If the patient is having anemia is what you have to basically remember. So what is one of the main mental challenges in entrance? How to remember the classification of the antiretroviral drugs. When you sit in reading room or library or anywhere in the home you are preparing, there are common challenges for every entrance going aspirant. So what is, are there any simple ways? You may have your own ways, but I will tell you some stupid ways of remembering. So anyway, you know Sri Lanka, Sri Lanfa is a very common mnemonic. Sakinavir, ritonavir, indinavir, lopinavir, emprinavir. These are all the protease inhibitors. Okay, then if you take any protease inhibitor, the general rule is what? They all end with navir. Then what is another easy way to remember? Life of pi. We all know, no? Don't tell Dr. Murali Bharadwaj teach is so stupid. Yeah, I like to become really stupid today. It is not a case of throwing a lot of knowledge. That is not the purpose of today. The purpose of today is how we can consolidate, remember, reproduce in the tomorrow's exam. Okay. So life of pi. So what will pi will do? Entire movie. He will be navigating. So pi is navigating navi. So protease inhibitors are all the ones which have got navir, some rare way of remembering. Then all integrase inhibitors end, they also end in vir. Integrase inhibitors is another class of antiretroviral drugs. But they actually end up as tegravir, like raltigravir, eltigravir, dolutegravir. They are all basically what? Integrase inhibitors. Then there is another important thing that you need to know. All PIs, protease inhibitors, they end in vir. But what is an exception? Abacavir. Abacavir is not protease inhibitor, though it is having vir. What is abacavir? Abacavir is a NRTI, nucleoside reverse transcriptase inhibitor is what you have to basically remember. So what are nucleotide reverse transcriptase inhibitors, NRTIs? Zidovudine, lambivudine, that is lam, and abacavir, and Didanosine. So you can remember a doe, a lamb, Abba and Dido. Okay, so they are the four important NRTIs is what need to be remembered. Then you have NNRTIs, non-nucleoside reverse transcriptase inhibitors. So how will you basically remember? When you write NN, you will be writing NN, and it has got a V and it has got a Everest-like appearance. So Everest is efavirenz, N is nevirapine. So nevirapine, efavirenz are called NNRTIs. Then what are called NRTIs? Zidovudine, lamivudine, abacavir and didanosine. Then all PIs have got a vir except abacavir is not a PI. That is what we need to basically consolidate. Then few comments on NRTIs. Whether you go for JIPMER, PGI, they are going to ask a question on important facts. 2 to 3 examiner always will have in mind whether you know it or not. So nucleoside reverse transcriptase inhibitors. What is the most important thing about them? Just like acyclovir. How does acyclovir act? Can you give me the board please? Acyclovir need to get converted into acyclovir triphosphate before it goes and inhibits the DNA production in the virus. Okay, that is the reason. What will acyclovir will be using? It will be using one enzyme of the virus called as thymidylate kinase. Using this, it will get converted into acyclovir phosphate and it basically interferes with the DNA replication in the virus. That's how it acts like an antiviral. Why will acyclovir resistance will develop? The virus at one point of time become very intelligent. It will think, oh, using my own thymidylate kinase, this acyclovir fellow is becoming a rich fellow and killing me. So it will create a resistant virus, would stop phosphorylating the acyclovir. In that scenario, what is the best drug that you can use to treat acyclovir resistance? Postcarnate is the drug. This does not require that phosphorylation step. That is the reason it is the drug of choice. So you remember acyclovir, no? Similar to acyclovir, even the nucleoside reverse transcriptase inhibitors are there, no? They also require phosphorylation with a kinase is what you have to basically remember. And how do they act? NRTIs. We will anyway review it while reviewing pharmacology. They competitively inhibit the reverse transcriptase inhibitor, NRTIs. And older NRTIs, they used to inhibit the mitochondrial DNA. If the mitochondria of the human body also get injured, what are the complications that occur? Lactic acidosis, hepatic toxicity, peripheral neuropathy. They are the classical side effects of the older NRTIs because of their inhibitory effect on the mitochondrial DNA is what need to be remembered. Okay. Then doctor, there are some classical toxicities which examiner favoritely asks. Zidovudine means what is the toxicity you will remember doctor? Anemia and neutropenia. Didanosine means acute pancreatitis which can be fatal. Then abacavir has got a very peculiar side effect. What is that? It leads to hypersensitivity syndrome. Abacavir. That's the reason you need to basically remember. Then how will I remember that abacavir will lead to hypersensitivity? Life has many things to pack and go for the exam hall, right? So abacavir sounds like a bee. Bee sting is hypersensitivity. some stupid way of remembering. Then emtricitabine, one of the peculiar side effects of it is hyperpigmentation of palms and soles. And all protease inhibitors, what is the class effect of them? There is a common side effect for all protease inhibitors. All protease inhibitors lead to lipodystrophy. Suddenly that emaciated HIV patient become chubby. His wife will come and tell, oh, what a nice doctor you are, and your medicine made my husband look chubby. Now I can be able to plant kiss anywhere on his circular face. But the problem is protease inhibitors are actually leading to the lipodystrophy. So please don't forget that. Then how about non-nucleoside reverse transcriptase inhibitors? Tell me, what are the two non-nucleoside reverse transcriptase inhibitors just before we studied? One is Everest, other is efavirenz and nevirapine. I said nevirapine? Okay. They are not competitive inhibitors. They are allosteric inhibitors. That is, they don't go and directly inhibit the active site of the enzyme. They inhibit somewhere else, they put on the switch and make enzyme get inhibited. Allosteric. दूर से control करता है. It controls from distance. That is the reason, if it is a competitive inhibitor, it should look like substrate, NRTI. NNRTI does not look like a nucleotide, hence called non-nucleotide reverse transcriptase inhibitor. And NRTIs require phosphorylation. NNRTIs do not require phosphorylation. Then one more thing about NNRTIs. They are metabolized by the P450 system in the liver. Okay, so that is the reason whenever you are giving NNRTIs, be careful to give any other drug which also acts on P450. Basically NNRTIs are metabolized by P450. If you use rifampicin, it is already a P450 inducer. That is the reason any NNRTI that you give become over metabolized, which makes it ineffective. So that is the reason, what will you remember? Whenever NNRTI is given, replace the rifampicin with some other drug like rifabutin, which does not affect the P450 system, is what you have to basically remember. Now 2-3 comments on efavirenz. Tell me, doctor, what is efavirenz as a class? Is a NNRTI. So it has got a very long half-life. You ask any HIV patient, what will he tell you? Hey man, how am I different from you? You are taking one thyroxine tablet in the morning, I am taking one efavirenz in the morning. You are taking it OD, I am taking it OD. It is an advantage and convenience. Take one efavirenz, only one tablet is sufficient. And it can lead to teratogenicity. Efavirenz, you need to be careful, unlike zidovudin. Zidovudin can be given safely to pregnant women, not efavirenz. If you give efavirenz, you will get suicidal tendencies. You are on the top of Everest. What will you feel like doing? Like jumping. So suicidal tendencies is what you get when you are taking Everest. That is, efavirenz is what you have to basically remember. Then coming to protease inhibitors, what is the point you will basically remember? It is a very strong inhibitor. Ritonavir is a strong inhibitor of 450, P450 system, please don't forget, right? Then how do they basically act? Why they are called protease inhibitors? There is a gag, there is a pole, two genes, they produce a polyprotein. This gagged pole polyprotein is prevented from getting cleaved if you are giving protease inhibitors, so that immature non-infectious virions get released whenever the virus replicates. So that is the function of protease inhibitors, is what you have to basically remember. Then another important thing about protease inhibitors is, if you take NRTIs or NNRTIs, they are acting at the very early stage of the viral replication. But protease inhibitors act at the last stage. Virus will think, oh nicely I replicated everything, it will pack the dress, everything ready to go to wedding and flight get cancelled. That is what protease inhibitor will basically do. Then another important thing is ritonavir boost. is one of the favorite question of the examiner. What is the meaning of it? Basically, ritonavir is a protease inhibitor. It inhibits P450. So that is the reason if you give ritonavir, it will cause the inhibition of any other protease inhibitor. That's the reason two protease inhibitors cannot be given together. That's the most important principle, and already you know lipodystrophy is the class effect of protease inhibitors is what need to be remembered. Then what are called integrase inhibitors? Raltegravir is called integrase. This is a favorite question. At least 3 to 4 times it was asked in AIMS question bank, All India question bank, and even our state MD entrance question bank. So you have to be very sure to remember what drug exactly is doing what. Simple expectations of examiner, not too complex. Then what is Maraviroc? Maraviroc is, if HIV virus is a helicopter, it requires a helipad to land. So whenever it is landing, it will land on a receptor, which is CD4. On the side of the receptor, you have co-receptors. CCR5 is co-receptor. So Maraviroc is a CCR5 co-receptor antagonist is what you need to basically remember, is what you need to know. Then enfuvirtide, what is it basically doing? It is a fusion inhibitor. It blocks the entry of the virus. Unlike protease inhibitor which blocks the release of the daughter virion, this prevents the entry. Enfuvirtide is a gatekeeper. Basically it will go and bind with GP41. Each of this is an MCQ. They ask what exactly is inhibited by enfuvirtide, GP41. Then which drug of all these drugs is given by subcutaneous administration? Enfuvirtide. And in what scenario you want to give enfuvirtide? Not to everybody. This drug is not for weak-hearted people, like this movie is not for weak-hearted. Enfuvirtide is given if all other measures of the drugs failed. As a last resort, you will give subcutaneous injection of enfuvirtide is what need to be remembered. So there are few fundas from which favorite questions of the examiner can come. There are many more fundas which anyway you need to get inspired to read. Right there. So my job is end of the day, if I finish 600 questions, make you inspire what is focused commonly in DNB, it's a successful moment. Okay. So Bhopal, Neelu, Krishna, Jugal, Anu, everybody who are online, don't feel sleepy. We will have a quiz after 2 to 3 topics. Last I told no 61 questions topics say I have, that we will use like a quiz, so that you will wake up, give some answers, so that you don't feel sleepy, I don't feel sleepy. Okay. So early morning almost 3 AM I was preparing, still punching few lines here and there. Suddenly I was having neck pain. I thought, oh, why should this neck pain come today only? Tomorrow is a big day for me. So but after meeting you, no fever, no neck pain, because I will take all your energy in. You think that teacher is giving energy? No. So we have to finish. What is a CNS tumor? Very common in immunocompromised patients having HIV. They lose the tumor surveillance. So CNS lymphoma is very common. What is the close differential diagnosis for this SOL? CNS lymphoma, toxoplasma. So you have a doubt whether it is a toxoplasma or whether it is a CNS lymphoma. So what will you do in that scenario? You will give around 4 to 6 weeks of pyrimethamine. See whether SOL shrunken. If it is shrunken, it is toxoplasma. If it is not, it is CNS lymphoma. You will do the brain biopsy, is what you need to remember. Now, the lamivudine is given not only for HIV but also for hepatitis B. One of the favorite DNB CET question is, what is the indication for giving lamivudine? What are the prerequisites in a hepatitis B patient? Is one of the most important question. if the ALT levels are more than 2 times that of the upper limit of the normal, that is one of the important prerequisites. Now let us quickly look into what are all the drugs which are used for HBV. Suddenly one question of HBV came here because of that common connection of lamivudine. Okay. We give pegylated interferon. What is pegylated? Peg is polyethylene glycolated form of interferon is something that you will give. Lamivudine, adifovir and entecavir. These are the 3 drugs which are typically prescribed for the management of hepatitis B. Now, whenever a patient of hepatitis B is there, he can be a non-replicative carrier. Lot of people will have hepatitis B carrier status positive, that is their surface antigen will be positive but they are not infective because their envelope antigen is negative, right? So if he is non-replicative and hepatitis B is sleeping in his liver, there is no need of any active treatment. Then suppose if the patient is a carrier, then what are the things that you will look for? If there is a normal ALT and an undetectable envelope antigen, if the HBV DNA is less than 10 to the power of 4, then if the DNA copies are small, lesser in number, then that is a scenario where you don't want to give any lamivudine. So if you want to give the lamivudine, what are the 2 important criteria in a case of hepatitis B positive patient? Number 1, his HBV DNA levels must be more than 10 to the power of 5 copies. That is one criteria. Second is, if his ALT levels are elevated more than twice that of the normal upper limit, that are the 2 important criteria that mandate you to give the lamivudine is what you have to basically remember. Suppose if the patient is envelope antigen negative, that means he is not replicating the virus, but he is a chronic hepatitis B case, then what is the indication for giving lamivudine is the next important part of the decision making. These 3 decisions are frequently tested in the entrance exam. A patient who is completely dormant, what will you do? You will do nothing. Then before giving lamivudine, what are the 2 important laboratory measures based on which you will give lamivudine? Second scenario. Third scenario, envelope antigen negative and chronic hepatitis B, what will you do? I leave the literature for you. So, prerequisites for giving lamivudine in a case of chronic hepatitis B is one of the favorite areas frequently tested in DNB CET, which you need to be quite sure. Now doctor, coming back to the HIV, there is an asymptomatic adult, CD4 count is 230, he falls under which category of CDC? You might have treated about 30-40 patients of HIV in your housemanship, but entrance is entrance, right? अगर पैसे नहीं है तो बार शॉप में क्रेडिट नहीं मिलेगा. जितना स्ट्रिक्ट है एग्जामिनर्स रूल, अगर आपका प्रिपरेशन सही नहीं है तो आपको हाई यील्ड फैक्ट्स मालूम नहीं है तो डीएनबी क्लियरेंस नहीं मिलेगा. You may say that no, I went for a mission in treating people, my hands are humane, you cry before examiner, he won't care. So what is the category of CDC? Fundamentally A, B, C are the 3 categories based on asymptomatic, symptomatic and number of the CD4 count. ये टेबल बट्टी मारना पड़ेगा क्योंकि HIV में anything you read is worth, because anything can be asked on HIV, but examiner without asking HIV, there will be no DNB CET paper. After you finish the exam, you come and tell me. If HIV question is not there in your DNB CET paper, we will resign from doing this classrooms. Okay, so it will come because we have to do it we are a country loving and living in the era of HIV. What is the window period of HIV infection? So fundamentally from the entry of infection to the appearance of symptomatology, I mean from the point of diagnosis, that is called as window. So typically it is around 3 months is considered to be the window, depending upon what did you use to detect the HIV. How can you detect HIV? One is you can do an ELISA, you can do HBV DNA. Depending on which criteria you use it to diagnose, window period is decided, but generally remember it as 3 months is the golden period. Now what is the meaning of CCR5 mutation? What is the meaning of it? Give me the board. So where does CCR5 come into picture? If the HIV is a helicopter, it will land on CD4 and there are CCR5 as co-receptors. Okay. So some people have a peculiar nature. What is that? They have such a type of CCR5 that will not let HIV to bind to it. That is the reason they may have about 50 sexual partners. Still they are not HIV infected. Just like we will discover some of our friends, they did not study at all, but they are in the top 10 ranks, and we studied all books in the world, but we are not in the bottom 10 also. We will be thinking how this happened. Think that our friends had CCR5 mutation, right? So CCR5 mutation confers resistance against the development of just like sickle cell anemia, confers resistance to getting malaria, like that is what need to be remembered. So you have CCR5 co-receptor, and which group of drugs we said? Maraviroc, Visiriviroc. What are all they basically doing? They are all CCR5 antagonists is what need to be remembered. When do you want to give prophylaxis for the pneumocystis carinii pneumonia is the favorite question of the DNB. इसके लिए एक calculation है which you should clearly remember. It is asked in 2011, 2009, June 2009, 2008, historical question. So if it is less than 200, then that is an indication for pneumocystis carinii pneumonia. If it is less than 150, it is an indication for histoplasmosis prophylaxis. If it is less than 100, it is for the toxoplasma prophylaxis. If it is less than 50, it is an indication for Mycobacterium avium intracellular prophylaxis is what you have to very, very clearly understand. Now what is associated with AIDS? These are all associated with AIDS. In AIDS you have an increased P24 antigen in the blood. You have abnormal mitogen assay, you have got energy. But what you have is hyper gamma globulinemia, not hypo. Why? HIV is a T cell mediated immunity compromise. If the T cell mediated immunity is low, who will compensate that? B cell mediated humoral immunity will compensate it. So that is the reason what you have is hyper, not hypo gamma globulinemia is what you have to basically remember. Then if there is a diarrhea in HIV patient, how do you want to basically treat? It is fundamentally a secretory diarrhea. That's the reason octreotide is the best drug to treat all the diarrheas which are typically secretory in nature, chemotherapy induced, etc., etc. If there is a acyclovir resistant human herpes virus, then what is the drug of choice? Already we discussed. Typically Foscarnet is the one which does not require prior phosphorylation is what you have to basically remember. Please ask them to get some more photocopies of the notes. See that everybody get the, how many don't have the notes? Yeah, you can collect, doctor, from there. How much is the seroconversion of the HIV needle stick injury? Oh. I had 2 times needle stick injury in MD. 2 months I took antiretroviral, efavirenz. I passed through all possible side effects, and that too, if you read, you topped entrance, you know everything about it. Taking the drugs is maza rehta hai. Huh? You close the eyes and whether really efavirenz cause or not, you will definitely get a nightmare. So to compensate that, we did some extra night duties. Right. First patient, next day only he died. Such a severe case. He had a cardiomyopathy. I was doing a pericardial tamponade tap. Pigtail catheter dalke. Suddenly it got plugged. Then our friends will be very eager. Let us check how much seroconversion will be there, etc., etc. And on the top of it, the chief will be joking. Oh, this guy is quite romantic. Before only you please check, already is he HIV positive. Otherwise he will tell that abhi ye injection ke wajah se hua bolega. So etc., etc. But life is enjoyable. The only miserable part is 2 months you need to have abstinence, which is the toughest thing. But otherwise the HIV needle stick injury and taking antiretrovirals, yeah. But let me tell you, doctor, after that around 20-25 people got needle injury stuck among our doctor fraternity. None of them were positive. So you need not worry. Actually, the beauty part is HIV dies with the exposure to the air. Such a polluted air, no doctor. HIV comes from another world. It thinks life is all that enjoyable outside the genital tract also. But it's not that enjoyable. It will die. So less than 3 in 1000. That means, do you know, doctor, if we are a sex worker, they have lesser incidence than us for chance of getting a HIV. Being a health worker, we have a greater chance than being a sex worker. So such a bad scenario is there. Right? So, but you need to be brave enough to treat the HIV positive patients. Oh, doctor, this is the dirtiest question on HIV in the entire DNB CET. Can you ask our guys to upload the notes into Edmodo so that our online students can download it? No tension, we will do that. West Africans में which strain? Sri Lankans में which strain? Indians में which strain? Not one time, 3-4 times same type of subtype of HIV was a favorite question of the examiner. HIV found in West Africans is HIV2. How you will remember, I don't know. Don't ask me. I will tell some weird methods. Africa is South Africa. There is no North Africa. So though it is South Africa, there are no 2 Africas, so HIV2. I mean, some last moment you will be hallucinating how to remember. Then what is the least common cause of seizures in HIV? Toxoplasma, lymphoma, cryptococcal meningitis, anything is possibility to lead to lymphoma. I mean seizures is what need to be remembered. But if I ask you, what is the most common cause if your patient of HIV is throwing seizures in the ward? HIV encephalopathy is the most common cause. Then what is the diagnostic test for HIV in the window period is a very important question. Window period means what? If you are trying to use ELISA, he is negative, but he has a history of exposure and he is infected. Then during that time, what is the best one? So the ELISA does not show an antibody, P24 antigenemia still will be positive. So it is the best investigation diagnostic test of HIV in the window period is what need to be remembered. So what is the window period is the favorite question of the examiner. If you use antibody testing as a method, 22 days, 3 weeks. If you use P24, 16 days. If you use nucleic acid testing, 12 days is the window period, is what you have to basically remember. A person is having CD4 count of 200 has a difficulty in breathing. I think this is what the 8th class student also will answer nowadays. Difficulty breathing, CD4 200 is pneumocystis carinii. Pneumonia is what need to be remembered. Now 2 points about pneumocystis, don't forget for entrance exam. Is the pneumocystis the most common opportunistic infection today? No. Because every HIV positive patient is nowadays receiving cotrimoxazole by default. Because of that, pneumocystis came down, UTI also came down. So it is not most common. Tuberculosis is still the most common opportunistic infection which you find in the patient who is immunocompromised with HIV. HIV neuropathy seizures. What is the second point about pneumocystis I want to tell you? If you look at a radiograph, what are those two findings if they are there? Two findings on radiology. They are against the diagnosis of pneumocystis carinii. Other cavitation if it is there, it is not pneumocystis carinii. Pneumocystis carinii is interstitial in pathology. If there are pleural effusions on a radiograph, it is not pneumocystis. It could be a simple bacterial pneumonia, which is not uncommon in HIV positive individuals. So pleural effusions, cavitation is against the diagnosis of pneumocystis carinii pneumonia is what you have to basically remember. Now doctor, HIV neuropathy and seizures, what are the causative organisms? Already we discussed Cryptococcus, Toxoplasmosis, CNS lymphoma, anything can lead to HIV neuropathy and also seizures, not the CMV. But in exam hall we try to guess the answer, we will definitely go wrong. We think of torch group of infection, if Toxoplasma can cause, why not CMV can cause? That's what after coming out of exam hall we will be saying, oh 200 out of 300 we answered. But how many of those guesses and stones will turn correct, only God knows. So go very predictably to the exam. Then what is the drug of choice for Toxoplasma? Pyrimethamine is the best drug. And if the patient is having ocular Toxoplasma, then along with pyrimethamine you need to give sulfadiazine or clindamycin, and sometimes along with prednisolone is what you have to fundamentally remember. Now, how will you manage post-exposure prophylaxis? What are the post-exposure prophylaxis guidelines of HIV is a favorite question in DNB CET. A patient has contacted an advanced case of HIV, then what do you want to basically give to him? Zidovudine, lamivudine, nelfinavir for 4 weeks. 4 weeks is the definite time. Now there is a protocol I leave in the literature given to you. It is not there in the literature given to you. This is not clear, even in your this thing. Okay, if it will be there in your CMDT, Harris and every book doctor, even if we pick it up, it will be from there only. But the point of interest here is, have you observed that it is important for examiner is the whole idea of my today's challenge. But anyway, what you can do is you can leave your email IDs with us. We will post all the PDF notes to you. You can also share it to your friends who have not come to the class. Knowledge is free, right? So we will give it to you. In that, at least I think the diagram will be more clear. Yeah. So what is the protocol for post-exposure prophylaxis? 2 nucleoside analog reverse transcriptase inhibitors given for 4 weeks if the exposure is less severe, or a combination of 2 nucleoside analog reverse transcriptase inhibitors plus a third drug which can be another class given for 4 weeks if it is a severe exposure is what you have to basically remember. So what does pneumocystis carinii basically cause? It leads to development of pneumonia. I think sometimes simple questions in exam hall. Commonest opportunistic infection is not pneumocystis anymore. It is Mycobacterium tuberculosis. Then which cells does HIV has predilection? CD4. Then what is highly specific test? Out of all, it is the Western blot, which is confirmatory, as all of you know very well. Then pneumocystis caria pneumonia we give, quatrimoxazole is what you need to know. Now I am going to ask you a quiz question. One quiz question to wake you up. For which of these you need to give me the answer. I am going to listen from you. For which of these patients would you recommend prophylaxis against the Mycobacterium avium intracellular? Option B you want to say, Doctor? 30 year, less than 50 copies. CD4 count of 20 and viral load of less than 50. CD4 of less than 50 or viral load of less than 50? CD4 is 20 is there, no? Okay. Which one? Mycobacterium avium intracellular. Exactly. One loud clap, one loud clap. Loud clap for the correct answer. Arey, come on yaar. Thali bajane se tera neem chale jata. So that is the whole idea. Huh? Subtype of HIV. Hottest topic of DNB CET. First I will show you how many times it was asked. HIV-E is more common. DNB CET most recent 2013 question is more common where? It is more common in Thailand. Thailand is 3. Oh, E. Okay, sorry. It is. Huh? Oh, Roman letter 3 looks like E. E is, that's how T is Thailand, T is 3 and Roman looks like HIV. One loud clap, loud tali bajao, loud tali bajao. That is the purpose of the today's class. And I am not listening. Oh, you didn't have breakfast or what? Come on, doctor. Come on. Loud clap. So that's good. HIV subtype seen in Africa. DNB CET 2013 once more. Maybe there are 2 sessions, no? Winter and I know what you did last summer. HIV subtype in Africa. Africa is subtype C. C. Is there any C in Africa? For us to remember. Some way to remember. Which subtype is common in India at least? That was a question in DNB CET 2014. Come on, who will give me a loud answer? C. That means we and Africans are our cousins only. Huh? Our cousins only. So C. Most prevalent subtype of HIV in India already. Once more 2009 DNB CET is basically subtype C. Next time if examiner asks a HIV question, you will remember me today morning. Huh? Definitely it will come. You are going to write JIPMER, PGI, AIMS, All India, DNB. 5 exams, no? After that, state entrance. That is the final part of the honeymoon. Huh? Final destination of the honeymoon. Yeah, every honeymoon spot has a suicide place, eco point, if you go to hill station. So, 2 major classes of HIV are what? HIV 1 and 2. America mein which one is prevalent? There is only one and only one America. So, oh, there are 2 Americas, North America, South America, but which is called USA? North or South? North. Oh, HIV 1. Subtype C is the most common worldwide. Sub-Saharan Africa mein subtype C. India mein subtype C. But America, Europe, Australia are subtype B is what you have to basically remember. And type C is prevalent not only in Africa but also in case of India and Nepal. And which one caused most infections worldwide? Africa में भी C है, India, Nepal में भी C है. Either you will find a brownie guy like us or a black guy like that. If you land in any airport in Europe or America, right? Every 4th or 5th person is a Sardarji in England. You feel am I in Punjab or am I in London when you go to London? Huh? So remember C. Then type E is in Thailand, the Roman analogy you will not forget. Okay, and ask your friends to remember Romania, Congo and other things. Your friends will remember, not you. So that is the story, doctor, of HIV. Okay.